Okay, let's spend a little bit of time talking about the neck lift part of the face and neck lift. So you may remember from the other video we talked about making an incision here, and then we also talked about making an incision here. Now, through those incisions, what I do is that in many patients, all I have to do actually is just reposition and tighten some of the platysma muscle laterally. Other patients, I have to do that and I have to tighten it up centrally in the midline in order to create some tensioning in the midline, some support and tension in the midline, and some laterally. Then most patients benefit, even thin patients benefit from sculpting out some of the fat that exists above the platysma, so above the muscle in this area of the neck where there should be a deeper crease, a deeper angle to it. That really helps highlight the jawbone. It helps really create a nice definition, a nice distinction between the face and the neck. And so removing fat directly under vision with scissors and with the cautery allows me really to sculpt out a beautiful neck. Some people use liposuction in this region, and there's nothing wrong with that. In my hands, it doesn't provide the kind of control that I would like to really create a smooth contour to the neck and a really highlighted concavity below the prominence of the jawline. So I like to do that fat removal under direct vision. And we'll have very full or descended submandibular glands. Submandibular glands are glands that exist beneath the platysma muscle, and they're salivary glands. So in combination with the parotid gland, and they're also minor salivary glands, the submandibular glands, meaning below the mandible, do make saliva. But again, in some patients, they have hypertrophy, or they've enlarged, or they've dropped in a way that it creates a little bit of fullness in a neck that adds some bulk to it. It takes away from some of the reveal of the jawline, and it almost afterwards look as if there's a little kind of walnut, if you will, or some lump in the neck. So in some patients where I anticipate that might be the case, I have a conversation with them about whether we do a submandibular gland reduction. I don't do it in everyone, and not everybody needs it or even wants it, but it's a good conversation to have with a patient. The way that I approach that can be either centrally or laterally, but it requires dissecting carefully underneath the platysma muscle, and then we just shave off the lower outer portion of the submandibular gland. So maybe removing a quarter of it at the most, maybe a third. I have not had any patients who's had any problems with dryness in their mouth afterwards. It is something that we counsel patients about. But again, I've not seen it, and I think the reason for that is that it is not the only salivary gland that contributes to saliva, and we're not removing the majority of it. We're actually leaving behind the majority of it, and we're leaving behind the portion that is attached to the duct so that the saliva that the remaining portion makes can push the saliva into the neck, into the mouth. Then one other thing that is done in that deeper plane is that there are some muscles called the digastric muscles. They're some of the deeper muscles of the neck beneath the platysma muscle. The anterior belly of the digastric muscle. So the digastric muscle, basically di means two and gastric means belly, if you will. So the anterior portion, or the anterior belly of the muscle, not really related to the belly of the stomach in any way, it's just terminology that we use as physicians. That anterior portion in some patients has become enlarged or hypertrophied, and by trimming off a little bit of the outer edge of that without really affecting the function of it, to bring it to the same level of the trimmed down digastric muscle, in many patients that can be very helpful in achieving a more contoured silhouette to the neck. So that's reducing the size of the anterior belly of the digastric, reducing the size of the submandibular gland. Those are both in the outer portions of the neck. And then some patients have a fair amount of subplatysmal fat. So I already talked about preplatysmal fat and dissecting that under direct vision, resecting that under direct vision. Some people have subplatysmal fat beneath the platysma, between the muscles and those glands, and removing a small amount of that to be in the same plane as the reduced digastric muscle and the reduced the reduced submandibular gland can create, again, a nice smooth contour, a nice shaped contour, and then again we just pull the platysma muscle over it at midline, suture together, and we really get a wonderful appearance to the neck.